You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 1st, 2025. This week, exercise and cardiovascular outcomes, aldosterone modulation, AI for ECG reading, GLP-1 comparisons, end-of-life decisions, and yet another well-meaning policy that caused substantial harm, this time in U.S. veterans. First, listener feedback. My former partner, Anthony Pearson, an echocardiographer, super smart person, and blogger known as a skeptical cardiologist, wrote to me about my comments last week on exercise. He wrote, quote, I was shocked to hear you quote major guidelines and numerous observational studies to support the concept that physical activity lowers cardiovascular death, etc. I was even more shocked to hear you discuss the 10,000-step study. Again, it's purely observational data, as if the higher step counts were reducing your CV death rate, etc. John, have you looked at the RCTs in this area? Why do you have such intense blinders on when it comes to critical analysis of the data supporting exercise and physical activity? You don't have to answer. I know why. The logic is that exercise is good. It's good for me. People should exercise more. We can't possibly critique the epidemiologic data that establishes the CV health benefits because that people might exercise less. At the very least, you should throw in a limitation statement when quoting these types of study. Non-sedentarily yours, he signs. I love this comment. Indeed, the empirical evidence for exercise is weak to non-existent. It would be nearly impossible to study lifelong exercise and cardiovascular outcomes. Problem A, of course, is the timeline. Problem B is the ethics of randomizing people to no exercise. And problem C is maintaining treatment adherence. You can no more study exercise empirically than you can study smoking cessation. Yet I believe exercise is one of those interventions that does not require randomized data. And I also believe that epidemiologic data is utterly confounded, not least because A, people who exercise regularly do other things that promote health, and B, there's reverse causation, right? It's surely present. That is, people who are healthier likely exercise more than people who do not because of their good health. And of course, C, is that scant few people can accurately estimate their exercise amounts. So my answer to the skeptical cardiologist, who is worth following and reading, he has an excellent blog, is that he is correct on the technicalities of the empirical evidence, which is terrible, but I'm also correct to promote exercise in the same way we could promote clean air and being kind to others. You don't need data to think kindness is beneficial, and I don't need RCTs to believe in the benefits of exercise. All right, next topic is aldosterone modulation in cardio-kidney disease. JACC, one of our top journals, has a state-of-the-art review on aldosterone modulation in cardio-kidney disease. I mention it because this is a classic scenario, isn't it? Right after the approval of a new expensive medication, you can bet there will be disease review articles. FDA approved the nonsteroidal MRA mineralocorticoid receptor antagonist finerenone on July 9th. Now, of course, we have a major review article discussing the two conditions for which the drug will be used, CKD and HFpEF. Now, this will be a brief topic because I don't want to be a broken record, but it boggles my mind that finerenone was not studied against spironolactone. Yes, finerenone beat placebo, mostly for non-fatal outcomes, but we don't know if it would beat the $4 per month generic spironolactone. Later on in this podcast, I will discuss a comparison drug study for the GLPs, which is the sort of thing we need more of these days. My points here are three. One is to highlight the pattern of seeing review articles that follow expensive drug approvals. Second point, I will be starting with spironolactone in these cases. And my third point is that MRAs are still the most underused drugs in all of cardiology. Go back and take a look at the RALS trial of spironolactone versus placebo in patients with HFrEF. is one of the largest effect size in cardiac therapeutics. 9% absolute risk reduction in death, and NNT to prevent death, 11. If I were the czar of heart failure therapeutics, I would push for more MRA focus. I see it nearly every week. A patient comes in with heart failure. They get sacubitril, valsartan, metoprolol XL, and dapagliflozin. 2 of these 3 drugs will crush the patient's budget. Far better, I think, for many patients who have normal American drug coverage, which isn't good, would be lisinopril at the highest dose possible, spironolactone and carvedilol given last and only when stable on ACE inhibitor and MRAs. I like to shoot for minimally disruptive care whenever possible, and minimally disruptive care is often finding the least expensive drugs for patients. All right, third topic today is an AI versus doctor ECG-Reading paper. The American Journal of Emergency Medicine has a neat study out this week comparing the accuracy of Cath lab activation for STEMI equivalent and STEMI mimic ECGs. I like this study, and it's an important problem as the identification of STEMI in the first minutes of a person's presentation is crucial. The aim of the study was to measure the doctor accuracy versus the machine learning-based AI algorithm from Queen of Hearts, which is a deep neural network model. You can use it on your phone. It determines the presence or absence of an occlusion MI. The PM Cardio STEMI AI ECG model received FDA Breakthrough Device designation in March of this year, but is yet to be cleared by FDA for marketing in the U.S. Americans need to wait for FDA approval, but there is an opportunity to get early access to the PM Cardio AI bot through a beta sign-up. It's available on Android and Apple app stores in the European Union and UK. Over 2,500 hospitals are on the waiting list, and it's currently being tested in pilot programs at over 60 global centers. For this study, done in San Antonio, in a hospital system that has 2 community hospitals and 4 standalone ERs, the authors chose 18 tough ECGs. Now, I know this because they actually put the ECGs in the supplement, and I had to really study them. These included 4 STEMI equivalent types, which require immediate reperfusion therapy. They added an ECG with Wellens T-waves and AVR STEMI. They also included transient STEMI and right bundle branch block, left anterior vesicular block, OMI, and a number of ECGs that would represent as STEMI mimics. These were included to test false positives, Cath lab activations. So, again, maybe you have the initial reaction that I had to this study, that these could be highly selected ECGs, and they might be selected to accentuate the MD-AI differences. And, maybe they were, but then when I looked at them in the supplement, these are real ECGs, and they're the types of ECGs that cause a lot of stress reading them, the kind of ECGs you see in peer reviews for missed STEMIs. Now, an important exclusion were ECGs seen in pericarditis, Takasubus, and Prince metal angina, since there are limited published criteria differentiating them from OMI. So in sum, there were about 12 ECG types that warranted immediate angiography and about 6 ECGs that were mimics and warranted no cath lab activation. And the ECGs were shown to 53 EM docs, emergency medicine docs, 42 cardiologists, and then, of course, the AI algorithm. And the reference standard was angiography. Was there an occlusion MI or not? And the outcome was a binary outcome, a cath lab activation or not. And the results, the interpretation accuracies were similar between emergency medicine docs and cardiologists, but both were about 66%. And both of these were hugely lower than the AI model, which accurately called cath lab activation in 89%. Doctors most frequently misclassified the De Winter pattern, transient STEMIs, and hyperacute T-wave occlusion MIs, as well as bundle branch ECGs. The Queen of Hearts AI algorithm misclassified only 2 ECG types, the left bundle branch block, OMI, the Sargosa positive, and left ventricular aneurysms. These ECG types were also challenged by physicians, with only 14% and 58% of physicians correctly interpreting them, respectively. Finally, emergency medicine docs missed 41% of true OMIs and overcalled 32% of non-OMIs, whereas Queen of Hearts missed only 11% and overcalled 11%. So the summary is that physician accuracy was quite low at only 2/3, This is consistent with prior studies. There was very little difference between emergency medicine and cardiologists. The ECG types most frequently misinterpreted, including left bundle branch block, transient STEMI, and hyperacute T waves, as well as de Winter T waves. And finally, the Queen of Hearts algorithm was more accurate than physicians, 89 versus 66%. And it correctly classified all ECG types except LV aneurysm and left bundle branch block. So my comments: I find this a remarkable study. The AI algorithm is clearly better for these ECGs. And the ECGs were very hard, but they're real, and I've seen them reviewed in peer review meetings where we review missed STEMIs. No one misses the 3 to 4 millimeter tombstone ST elevations. It's these subtle STEMI equivalents and STEMI mimics that are tough. If you're a patient with an occluded LAD but not a conclusive ECG, you hope either for good luck or a master ECG reader or perhaps a really good AI algorithm like this one. Now, scientifically, I wonder if the best solution is smart doctors who have seen the patient, and so they have this Bayesian priors based on history and general appearance. For instance, patients with MIs look like patients with MIs from the door, plus AI versus just AI. Now, this is a false comparison because I don't think that a study will ever be done with just AI, as it's hard for me to envision an ER without a doctor. But I could not have imagined a medicine without smartphones before smartphones, so you never know. Nonetheless, I don't know why FDA would not approve such a device for use. It looks like an important adjunct for getting to the proper diagnosis. I see it as similar to using point-of-care ultrasound for central venous access. Sure, you could get into a central vein without ultrasound, but why would you? So in the case of ECGs and Cath lab activation, sure, you can do it without AI, but why would you? These STEMI equivalents and STEMI mimics aren't rare, and the Queen of Hearts looks quite good. And technology is amazing. All right, next topic is GLP news via press release came this week. Eli Lilly, the maker of Tirzepatide, which is a GIP-GLP-1 dual agonist, announced results of the SURPASS cardiovascular outcomes trial, SURPASS CVOT trial. And this was comparing Tirzepatide to Dulaglutide, which is Trulicity, in patients with diabetes and established cardiovascular disease. The trial began in 2020. It enrolled about 13,000 patients, and the company reported the top-line results this week. Now, Dulaglutide was shown to reduce cardiovascular outcomes in patients with type 2 diabetes and established cardiovascular disease or high risk for CV disease in a trial called REWIND. And this was published in Lancet 2019, and REWIND results were close on the primary endpoint of MI, stroke, and CV death. It was 12% in the Dulaglutide group versus 13.4% in placebo. That hazard ratio in REWIND was 0.88, confidence interval 0.79 to 0.99, and a p-value of 0.026. Now, in the SURPASS cardiovascular outcomes trial, Lilly says the risk of cardiovascular death, heart attack, or stroke was 8%, relative risk lower. Tirzepatide versus Dulaglutide, that hazard ratio was 0.92. Confidence interval 0.83 to 1.01, p-value 0.086. And you think, oh, that didn't meet the criteria, but it did meet the pre-specified criteria for non-inferiority. Now, Tirzepatide showed consistent results across all three components of the MACE. The rate of all-cause mortality in the press release was noted to be 16% lower. This hazard ratio was 0.84, confidence interval 0.75 to 0.94. There were also positive results in secondary endpoints. There was a slower slope of eGFR decline. There was more reduction of A1C and a minus 12% versus minus 5% body reduction with Tirzepatide versus Dulaglutide. Key opinion leader Muthu Vaduganathan wrote on X that, quote, "The game has changed. SURPASS CVOT meets its primary and secondary endpoints in the first head-to-head CV outcomes trial." He emphasized the 16% lower risk of all-cause mortality. Yet, the always reasonable Dr. Sanjay Kaul on Twitter noted that SURPASS was powered for a 15% relative risk reduction in MACE, and the primary efficacy endpoint comes out only 8% lower, with 95% confidence intervals going from 0.83 to 1.01, and that barely contains the hazard ratio of 0.85 for which the trial was powered. Kaul also notes the superiority of the comparator here, Dulaglutide, has not been established in this patient population. Now, you might question that. What? I told you the Rewind trial of Dulaglutide versus placebo was positive. And yes, it was, but Kaul notes that the subgroup of patients with established atherosclerotic vascular disease, about a third of the patients in Rewind, the hazard ratio of Dulaglutide versus placebo was 0.87, but the confidence intervals went from 0.74 to 1.02. Kaul also asks what to make of the 16% reduction in all-cause mortality, and I think this is a good question because you only have an 8% reduction in MACE, and Lilly tells us that Tirzepatide reduced A1C, body weight, and slowed chronic kidney disease, but no significant difference in CV events. My 2 cents here are that all-cause mortality is likely to be a noise issue. The p-value was not adjusted for multiple testing, but more important is that if a drug is a cardiac disease modifier, then CV death and CV outcomes should drive the reduction in death, and we need to see the full trial results. Another issue is that Tirzepatide was titrated to max dose and Dulaglutide was fixed at 1 dose. And finally, I have a real problem with the non-inferiority design here. Non-inferiority designs are to be used for interventions that offer something less invasive, less costly, or less risky, and I don't see any of that true with Tirzepatide. In these early trial results, my take-home is that Tirzepatide failed to show superiority over Dulaglutide. The hazard ratio was only 8% relative risk reduction, and the confidence intervals went above 1, with a p-value well above our established threshold of 0.05. We'll have to wait for details of the full trial presentation, which I understand will be presented in September at the European Association of Diabetes meeting. All right, next topic is end-of-life decisions. The BMJ Ethics Journal published a survey of physicians' preferences for their own end-of-life. The survey included docs from Belgium, Italy, Canada, U.S., and Australia. More than 1,100 responses were analyzed, and physicians rarely considered life-sustaining practices a very good option in cancer and Alzheimer's, respectively. CPR resuscitation 0.5, 0.2%, mechanical ventilation 0.8 and 0.3%, tube feeding a little higher at 3.5 and 3.8%. About half of physicians considered euthanasia a very good option, respectively 54% and 51%. Physicians practicing in a jurisdiction with a legal option for both euthanasia and physician-assisted suicide were more likely to consider euthanasia a very good option for both cancer, odds ratio 3.1, and Alzheimer's, odds ratio 1.9. Now, I cover this short paper because I continue to be struck by the severity of illness in hospitalized patients. Nothing has changed from when I started 29 years ago. I used to remember coming home and telling my wife, Stacy, how much we were torturing these older people in ICUs. And that was in the 1990s. Well, it's the same. I see consults nearly every day at our place, and many of the people we are asked to see because of VT or AFib or bradycardia are literally weeks or months from dying. Not of the arrhythmia and not of one disease, but rather a multitude of diseases resulting in severe frailty. So you read this survey of doctors and you get the impression that since doctors know better, they would not be stuck in this loop of hospitalization and ICU stays. But whenever one of these surveys on doctors' preferences comes out, I go back to Dan Matlock's paper in 2016, and it's titled How U.S. Doctors Die, a Cohort Study of Healthcare Use at the End of Life. They actually found when looking at Medicare data of U.S. docs, doctors spent the same number of days in the hospital and ICU in the last 6 months of life as did non-doctors. Doctors in this study did spend a few more days in hospice than non-MDs, but the take-home was that while doctors may express a desire not to have fetal care at the end of life, in reality, they suffer as much as non-doctors. Now, no idea that I've had gets stronger than this one. The idea is the challenge of modern cardiologists is not having something to do for people, but whether we should do it. With every new advance of percutaneous valve procedures, PFA for AFib ablation, CTO, PCI procedures, the question of using these procedures in older, sicker patients gets harder and harder. I mean, we can do TAVIs and open up valves. We can put in pacemakers and fix bradycardia. We can put in CRT devices and fix left bundle wrench block. And now with PFA, we can ablate about anything in the left atrium. But in many of the inpatient consults I see, none of what we can do in EP or in cardiology can fix the dying process of old age. These are super hard decisions, and I don't have an answer for all the suffering we inflict in the last months of years of life. One specific example, take VT ablation, for instance. It's one of the sexiest, newest movements in EP. On X, you see tons of it. Gorgeous pictures of these diastolic buffets of electrograms, colorful 3D maps. But I will tell you that in reality, many of these patients have VT because they have end-stage cardiomyopathy. Now, you want to, of course, have the skills to ablate VT because a minority of patients have an isolated scar that can be ablated, and that patient can then live years of good life. But gosh, many of these patients have VT because they've successfully survived an MI and heart failure for 20 years. They've had a great run. And I don't mean to be preachy in this topic. In reality, I often don't know when to stop, but I do know that stopping is often the right choice. I would remind listeners that all of us humans have end dates. And the job of a modern physician, more and more, is to help people have a good life and good death. We are much better at the former than the latter. All right, next topic, final topic, is well-meaning policies that make sense. I want to close today with another chapter on these well-meaning policies that make good sense. It's one of the most dangerous concepts in healthcare. A few years ago, here in the U.S., there was an uproar about access to care in VA hospitals. Veterans often live far from a facility, and there were also substantial wait times. So, Congress passed the Mission Act, which stands for Maintaining Internal Systems and Strengthening Integrated Outside Networks. This Mission Act allowed veterans who lived longer than an hour drive to get care outside the VA, closer to home, because that makes sense. Well, JAMA has published a very interesting observational study of cardiac outcomes from the Mission Act. The authors, led by a team in Philadelphia, did a retrospective difference-in-difference cohort study of veterans who had PCI CABG or AVR between 2016 and 2022 in non-VA hospitals covered under the Mission Act or in VA hospitals. The two outcomes were MACE, MI stroke or hospitalization for CV cause or death within 30 days of the procedure, and travel times. This was a huge database study looking at the three procedures, tens of thousands of patients in each group. The two main groups were patients who lived far and patients who lived near. Now, the first finding was that Mission Act implementation for PCI, CABG, and AVR, there were much larger percentages of far rather than near patients who received these procedures in non-VA hospitals. So the Mission Act did accomplish that veterans who lived far from a VA hospital did get more procedures outside of the VA system. The second finding and hint is that far patients who received procedures at non-VA hospitals were more likely to receive care at non-teaching, smaller, rural, and for-profit hospitals than near patients receiving non-VA care. The third finding was to look at outcomes before Mission Act, October 1st, 2016 to June of 2019. The difference in travel times, the probability of choosing the VA and 30-day MACE showed no statistically significant differences between the two groups. That's important because it provides support for the pre-intervention parallel trends assumption critical to the validity of difference in difference analyses. So basically, in other words, before the Mission Act, there were no significant differences. But after the Mission Act, which was implemented in 2019, travel times increased a tiny bit in near patients, but decreased by a lot in far patients. I think the travel time increased a bit in near patients because it was not just distance, but also wait times that could allow veterans to go to other hospitals, and non-VA hospitals may be farther away than the VA. Indeed, PCI, CABG, and AVR volume in VA hospitals decreased quite a bit after mission implementation, but here's the key results. FAR patients, FAR veterans, undergoing PCI had a 2.3 percentage point adjusted mean increase in 30-day MACE rates compared with a 0.5 percentage point adjusted mean decrease in MACE rates among near patients. So the difference in difference was 2.8 percentage points, highly statistically significant. FAR patients undergoing CABG had a 1.6 percentage point adjusted mean increase in 30-day MACE rates compared with a 6.5 percentage point decrease among near patients, and that difference in difference was huge at 8.1 percentage points. And near and far patients undergoing AVR had similar adjusted mean increases, so there was no difference in difference for AVRs. And the authors concluded that, quote, Mission Act implementation was associated with substantial decreases in travel time among veterans who became geographically eligible for non-VA care. For these patients undergoing PCI or CABG, Mission Act implementation was also associated with worsened 30-day MACE rates. My comments. I remember thinking this was going to be the likely result. Yes, it's nice to get care closer to home. I often see rich endurance athletes who travel to see me. If they should have a procedure, I tell them to get it close to home. Well, that's because AF ablation is a well-practiced procedure that can be done in all major cities. But PCI, CABG, and AVR are procedures that not only require a skilled doctor, but also a skilled team and a system. And while VA hospitals may not have the best food or the greatest decorations, they often have great processes and dedicated staff. In fact, in the introduction of this paper, the authors cite 3 observational studies finding that VA cath labs have better mortality rates than non-VA cath labs, and I don't find this a surprising finding at all. So the Mission Act focuses on improving access to care as if that's a good thing, and it does. Veterans have shorter drive times to get care, but increasing care outside the VA results in worse results, at least for PCI and CABG. Now, I should add that this is observational and there may be confounding. While baseline characteristics in the 2 groups, near and far, were similar, those who live farther from the VA may be sicker. But I doubt this is a confounder here because if there's one thing that U.S. hospitals are good at, it's making patients look sicker on paper. So, I find these results highly likely to be right. Care in the U.S. has lots of variability. VA care, on the other hand, is pretty standardized. I see a similarity to, say, Canadian healthcare. When I visit Canada, I'm struck by how cardiac procedures are done in small numbers of hospitals. So large volume, small numbers of hospitals. This means that Canadian patients having procedures have doctors and teams who do a lot of the procedure. Now, they may have to travel, they may have to wait, but when they have the procedure, it is done by experts. Now, in the periphery of major cities in the U.S., it's the Wild West. For instance, in Louisville, there's about 8 or 9 centers doing AF ablation. Now, you may get a skilled doctor in the U.S. who has tons of experience, but you may not. This paper suggests the policy of allowing veterans to seek faster and closer care resulted in worse outcomes. And the lessons, as they always are both specific and general. Specifically, it was a bad idea to think that in the U.S. more convenient health care was a positive. And generally, it would have been far better to implement this policy in an RCT pilot form first. Then, instead of looking back and seeing all this harm that it caused, policymakers could have adjusted midstream and maybe mitigated the harm. I don't know why we feel that trials are needed for new drugs and devices, but not policies. In fact, policies may affect more people than drugs and procedures, and I think it's even more important to study these in RCT form. So that's it for this week in cardiology. As always, I'm grateful that you listen. Remember, if you like this podcast, please give us a rating, write us a review, and by all means, if you don't agree with something I said, send me an email, write a comment, and we'll make it into listener feedback. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.